All right, welcome everyone to our May Grand Rounds. My name is Mariel and I will be your host for today. Before we start, I'd like to just go over a few things. This presentation will be recorded and uploaded to our YouTube channel. If you wish to watch our videos on YouTube, there's an option of playback speed to adjust the speed of the video. Also, on Zoom, you may turn on the feature called closed caption during the presentation to allow for subtitles. And with that being said, I'd like to hand it off to our medical director, Dr. Pecchia.
Thank you, Marielle. And as most of you know, I am Gregory Pecchia, physician and the medical director of Global Offsite Care, family physician and geriatrician, as well as the director of telemedicine at Western University of Health Sciences in Pomona, California, and a campus also in Lebanon, Oregon. And today we are honored to have with us to continue our series in case presentations in various settings. And specifically, we'll chat a bit about how telemedicine can facilitate that. And we have today Dr. David LaRue. He is a board-certified physician in family medicine, trained at Western University of Health Sciences in Pomona some years ago. After that, and his residency in family medicine with the Kaiser Health System, he then practiced in that system for 35 years, and in the last 10 years has had clinical experience in the emergency room, urgent care, and sports medicine. He's semi-retired and has had the opportunity to visit Machu Picchu in Peru, floating islands of Lake Titicaca, the Italian-French Alps, and has hiked the Milford Sound Trek in New Zealand. He's married with 2 adult sons, one of whom is a community college professor and the other a real estate entrepreneur. Dr. LaRue is interested in philosophical theory and mindfulness training. And while he does that, he also plays rhythm guitar and sings with a band in San Diego, California. So, Dr. LaRue, welcome again. Thank you so much for joining us and contributing to our archives in case management in the global arena. In this case, actually Southern California. So, Dr. LaRue, the floor is yours.
Greg, Mariel, thank you very much. And thank you, everyone, for joining me this morning. And thanks for the introduction, Greg. You read my whole bio that I wrote. Mariel had cut it in half, but thank you for that. I wanted to introduce myself to the group a little more. I think what I bring to the table today to share with you is my 35 years of experience, in clinical medicine. And through that, I've probably accumulated a good 200, 300 cases that I've tracked and documented to eventually share with people. And throughout that 35 years, I've never given a PowerPoint presentation, so this is my first. As I was preparing this, it asked for themes. It was interesting, and I was clicking around at different pictures on the themes, the theme possibilities, and I saw this drummer. And I thought to myself, wow, I thought 2 things. This courageous, intense drumming, and I thought of chaos, and I thought of, more so with this drummer, probably very organized chaos. And I also thought about immature skeleton, still with growth plates, which is a common thing we see in urgent care, which is trauma to the immature skeleton. The next thing I thought of, back to the first thing about a chaotic or organized chaos, is what I'm striving for in my urgent care clinic and any primary care clinic with a walk-in situation. So the next thing I did was I found this picture of, oh gosh, my first 6 patients of the day, probably within the first hour. And so here we go. Finger let's see here. And finger, swollen foot, quote unquote, chief complaint of dying. And I just throw that in there because literally it can be anxiety, as we all know, but it can also be shortness of breath and congestive heart failure or impending pulmonary edema. So all of this is chaotic and trying to keep it organized. Cut finger, I mean, this can be a small slice or, cut the finger off, which we see. Medication refill, urethritis, loose bowels, and the list goes on. Back to our drummer. With pediatric trauma, any trauma, I tell my patients, the most important thing is recreating and understanding the mechanism of injury. So, most commonly, we humans will extend our hands out, palms down, and land on what we call the foosh, right? Falling on an outstretched hand. And that leads to certain stresses that will lead to certain more common type of fractures. But today we're going to start with the elbow. We're going to talk about the elbow. I might switch back and forth a little between adults and pediatric x-rays so we can see the difference, but here we go. This is a lateral elbow at 90 degrees of about a 10-year-old child. Humerus, radius, ulna, and then this chaos of growth plates. And I do this, I see these cases twice a day, but even doing that, I have to look this up every time. And I look it up, I have a picture of it in my office, and it is one of the key things in pediatric trauma is knowing or being able to look up the years of the growth plates, where they are ossifying, and when they'll close, where this lucency will be gone. You have to know that, because if you don't, you'll think this olecranon ossification center is a fracture, and it's not. This is a normal x-ray, a normal lateral x-ray of a 10-year-old pediatric patient like our drummer who fell off and had a foosh, fall on an outstretched hand. Okay, I'm going to skip around here because as I was reviewing slides, some of them are way too busy, and I want to try to keep it simple. What you're going to do with the lateral x-ray in an elbow case in a kid is you're going to, there's a lot of names, and again, I have this picture in my office, but all you really have to do is make sure this anterior humeral line is running through the capitellum. I'm going to show you an abnormal, but this is normal. This anterior humeral line has to run through the capitellum, about the middle of it. The other line you draw is this guy. Proximal radial line right through the bone marrow, center of the bone, and that should also bisect and run through the capitellum. Okay, let's go to this. It's going to be a busy slide, but we're going to concentrate first. Again, here's our normal. If I were to draw that anterior humeral line, here's the capitellum. It's running through the middle, proximal radial line running through the middle of the capitellum. This is our classic foosh fall, and there are so many different types of fractures, but I'm going to only talk about this one. It's one of the most common, and it's one that can be easily missed. Here's our anterior humeral line, and clearly This completely misses the capitellum. Now, this is pretty good, actually. The proximal radial line is normal, but here's the fracture, right? This distal humerus is fractured, and the distal fragment is pushed posteriorly, proximal fragment anteriorly, and this is a potential disaster, but this is an obvious one. I can tell you that you can have a totally normal looking x-ray like this, and there can still be a small supracondylar fracture. So with these kids, if it's obvious, we're splinting and we're sending to the ER and they're going to see pediatric ortho and probably get reduced and pinned that evening or the next morning. If it's not obvious, we're still going to splint and assume there's a fracture up in here, even with normal lines if there's enough pain. And then this is just an obvious dislocation. So I think the point of these x-rays are just be careful. You can see a normal, and you have to have a very high index of suspicion if it's a kid that there's still a fracture in there somewhere. This is an obvious anterior humeral line completely missing the capitellum, and another obvious, this dislocation in an adult. Okay. Let's go back to the mechanism. Foosh fall from our drummer, outstretched hand. You're thinking fracture. You got to draw your lines. You got to get your x-rays. Or if you don't have all of that equipment, you're just going to splint. Always in a kid, you're going to assume it's a fracture because the growth plates are much weaker than the muscles and tendons. So you're always splinting, and you're saying you're going to see an orthopedic person, within the week. Here is a different mechanism. This is our so-called nursemaid elbow. So this is not a foosh fall. This is from playing with your child, protecting them from running into traffic, and you're kind of yanking on their arm to keep them safe. And what happens with this is the radial head comes out, subluxes out of the radial annular ligament. And this child will come in, won't want to move its arm, nursemaid's elbow, radial head subluxation out of the radial annular and ulnar ligaments. Again, the mechanism is most important because with this mechanism, between a usual 1 and 5-year-old, you don't even need x-rays. You can sometimes this is fixed on its own. It's a very simple fix, which is, okay, I'm going to try. So with a nursemaid elbow, the child's not going to want to move. I use a little distraction. I'll try to have them play with a toy. They'll play with their hand that's good, and they'll consider reaching with the bad hand, but they'll start crying. But again, this is the mechanism of injury. You know that this is not a serious injury. This is a nursemaid's elbow where it was pulled axially and the radial head was slightly subluxed, dislocated away from the radial annular ligament. And all you have to do is either, there's two hyperpronate, you can just practice on yourself. You're going to grab this child after you talk to the parents and you observe and you're ready to go. You're going to pronate, and it will actually click about 80% of the times back into place. You will hear or feel the click. If that doesn't work, and I usually do both at once, I pronate, then I supinate and flex. Works every time, like a charm. And then you leave the room And about 10 minutes, and you encourage the parents to have the child play with a toy or whatever is interesting to them, and literally 5 minutes later they're using their arm and have completely forgotten it was subluxed. Okay, so that's my first case about elbows, pediatric elbows, and I would just say that again, the mechanism of injury is most important, and if it's a foosh fall, you want to assume there is a supracondylar fracture. It's one of the most dangerous because of the arteries and nerve supply that run right over the anterior humerus down to the rest of our arm and hand. You want to assume there's a fracture, and if you want to err on the side of caution and splint these kids, which is actually a long arm posterior splint, which is going to prevent pronation, supination, prevent flexion extension. You will be sending them to the ER, to ortho, at least that day or during the week. And again, this is normal x-ray with our lines that we're going to draw, anterior humeral, radial capitellar. Let's see if we can find this abnormal.
Dr. LaRue, time for question?
Yep.
Yeah, for this kind of fracture, so many of our projects are in settings that do not have x-ray and cannot, that there's no orthopedist to send them to, right?
Yes.
And they may be in a remote village days away from anything like that. So a couple of questions about which you may or may not be able to answer, but if not, we can append some of the answers to a follow-up to
Sure.
this meeting. But what would the typical treatment be if this patient were able to be treated directly by an orthopedist? And if not, is there a place for using telemedicine connectivity to direct a healthcare professional in real time or asynchronously about how to manage this fracture the best that can be managed remotely? And then another question is, with the advent of handheld ultrasound being now able to diagnose particular sorts of fractures, so that, which is an amazing thing to be able to have if x-ray is not available. For elbow injuries, is there any literature that we might think about looking at in using handheld ultrasound to diagnose not only an injury like this or these types of injuries, but also, other fractures?
Yeah, that's, of course, great questions, Greg. Yeah, in my setting, and we use the X-ray only, the plain film. Clinically, if you don't have an X-ray, clinically you are, I would say that you're able to kind of assess how potentially serious the injury is, because obviously on the extreme, if it's broken the skin, if there's a compromise vascularly, say, a cool, pale extremity, a dropped wrist, unable, we often play the game of rock, paper, scissors, which is just, moving the fingers, adduction, looking for nerve damage. If it's obvious, then that patient has to somehow, hopefully, will be splinted and get to an emergency higher level of care. If it's mild and we're palpating the bones and everything's working except there's just pain to palpation over certain bone, I think splinting and even rechecking the child in a situation where you don't have where you're only doing physical exam, say rechecking the child every 24 hours is what I would do. And then you say the ultrasound literature on fractures is immense. I'm not aware of it enough. I've read some of it, but that would be, if someone was skilled with a bedside diagnostic ultrasound and could send that picture through telemedicine to an orthopedist, that would be, I would say that would be a top of the line standard of care for a rural clinic.
Great,
Right.
great. Yeah, and that helps us also kind of go down that pathway and create perhaps a protocol for our projects who are in that very situation so that they can plan forward, anticipating they're going to see injuries like this. I'm sure they already do, and give them another pathway, another off-ramp, if you will, for management that, may allow them to treat on site if it's non-surgical treatment, if that can end up being appropriate or the best that can be done. That's super helpful to know that. So thank you for that.
Absolutely.
Yeah, and being mindful of time, right? We probably should move on to case 2.
Okay. So this is a 40-year-old male, had a puncture wound. He ran his shin into a metal table at his home and presented to me, I'd say 24 hours later, the next day. Past medical history, he has diabetes type 2. It's well controlled. Moderate obesity, moderate alcohol intake, and I wanted to show both legs because in the first 24 hours, both of his legs looked like this. Of course, this is normal leg. 48 hours later, he came back in extreme pain. Extreme pain. He was almost writhing and holding his leg. A fever of 103. Rigers. Heart rate 130. Blood pressure 90/60. So there's the puncture wound. It was actually, this was honey crusted, but it had, I gently touched around it and actual purulent material came out of this puncture wound. And his calf was twice the size of his normal leg. And I felt like his great toe on the infected side, great toe was cool and pale. So this person, clearly to me, in my clinic, I'm thinking, is this just a superficial cellulitis, which we can treat as an outpatient, as you all know, or is it invasive and could it be necrotizing, specifically necrotizing fasciitis, which is what this patient had. So with necrotizing fasciitis, it's very aggressive skin and soft tissue infections. It's often from a puncture wound. The comorbid risk of getting this is alcohol intake, diabetes, cirrhosis, and smokers, peripheral vascular disease come to mind. I'm sure there are more. And the bugs are often gram-negative, gram-positive, aerobic, as well as anaerobic possibilities. So Clostridia, Bacteroides, coliforms, strep, staph. These people are very sick. They end up in the ICU. Let's see what antibiotics. I wrote this down. I can't find it, but I think imipenem, let's say in the old days, because I'm old, triple antibiotics to cover gram-positive, gram-negative, and aerobic, anaerobic, till you maybe get a blood culture or a wound culture, and then surgical consult, because these people have to be debrided and often get compartment syndrome and have to be drained and surgically managed as well. Let's see.
Question.
I wanted to just contrast this rash that comes in. To me, it's a rash, and the range of the way I think of a rash and changes of the skin, is it going to be superficial or is it going to get very deep? And if it's going to get deep like this, they're going to have rather severe systemic symptoms. I'm going to click to this one because this is just to contrast that. Here's a small scratch. It's not a puncture wound, but it's a scratch. And there's a little bit of some honey crusted, just some vesicles here, not necessarily honey crusted, which implies staph, but some vesicles here. And this is something that we see often. I see maybe twice, 3 times a month in the clinic, because patients get a scratch and then many of them apply Neosporin ointment. That this person was even covering it with saran wrap and a Band-Aid with Neosporin, and this is a common thing we see. And of course, this person had no fever and no pain and no systemic symptoms, and just kind of irritative, itchy rash. And this is a Neosporin contact dermatitis. So in general, I usually just have patients use petroleum jelly to moisten a wound, and I avoid Neosporin. So there we go, two rashes and 2 extremes in my chaotic, back to the theme, my chaotic, potentially chaotic clinic.
There we go. And the question that came up in the chat, Dr. LaRue, is from Jason. Do you find any usefulness of tools like the LRINEC criteria, which is a scoring system for screening for perhaps earlier detection of necrotizing soft tissue infections?
Yeah, thank you, Jason. I looked that up in some of my readings, and in general, Jason, for me, I clinically, if I have a high index of suspicion, this patient for me is certainly heading to the emergency room. I don't know if my infectious disease colleagues, my surgical team use that, but for the audience, it's a C-reactive protein. It's a WBC, hemoglobin, sodium, creatinine, and glucose. And I guess I would think about it like this. For cases that are not obviously necrotizing, somebody's heading towards sepsis, or is this just more of a superficial cellulitis, I think that then this lab risk indicator can come in very, very handy. I would use it. And I also think I read about ultrasound or MRI to look at the fascial planes and see if there are findings of necrotizing fasciitis. I would have to review that, but great question. Yeah. Yes, for the cases
and again, in the remote setting, right, which is kind of where we at Global Offsite Care spend a lot of our time and resources. Yeah, having a tool that could leverage some readily available labs, all of these types of labs, and using this tool, CRP, white count, hemoglobin, sodium, and creatinine, those are all readily available by simple low volume labs with relatively inexpensive equipment on site. And then to be able to use also still images, perhaps photographs that can actually be analyzed with the help of some AI, so that we, then again, have the capability of diagnosing and treating people on site. Obviously, we need to be prepared with the correct antibiotics, et cetera, IV access and the like, and perhaps some real-time televideo for assisting the medical team on site for the patient. Again, in the event that you wouldn't necessarily be able to take this patient, put them in an ambulance and send them to a hospital. No ambulance, no hospital. But if we've got internet, perhaps even through the sky, and handheld ultrasound to rule out other conditions like deep vein thromboses or loculated, fluid collections, pus, etc. I think, we end up having a capability that isn't necessarily optimal, but it's definitely more optimal than doing nothing. So appreciate that
Well
case. That's a
said.
great case.
Well said.
All right. In the interest of time, let's go to the next case. Dr. LaRue.
This is, I guess I'll kind of say this is a potpourri of foreign bodies. So here is something we run into in San Diego quite a bit. So this is an encounter with a marine sea creature. And these patients come in from the beach. They were either surfing, walking on the beach, jogging, swimming. But this happens when they're either entering the ocean or walking out and leaving. And they will complain that they think they stepped on a coral reef or glass or a rock or anything that causes severe pain. And they are in severe pain when they come into the clinic. They're holding their foot in the area that was inoculated. And we often know what has happened already because we practice here right off the Pacific Ocean, and this happens a lot, probably 3 times a week. But here's some x-rays. I just want to tell you this is the calcaneus. This is the actual foreign body. Sometimes when I'm going to remove the foreign body, this is just one of my 18 gauge needles aligning with the foreign body so I can find it and remove it, because sometimes that's difficult to do. So again, these patients are in a lot of pain. Here's another one in the foot. This is a metatarsal phalangeal joint. Here's a big foreign body. Here's the foreign body after I remove it. Let's see, is this big enough? Let me enlarge that. Marielle, here we go. Maybe that's better. But this is interesting. And I'm sure you all know, or you're thinking what marine creature this is. Hope I get the right marine creature. This is actually a photo from one of my son's scuba trips. I know some species have the spine and some don't. This was such a beautiful photo, I put it in here. Back to this. These patients are in severe pain, and basically this is a stingray. They stepped on a stingray or got close enough and got poked. There's an exotoxin that will cause severe pain, and the exotoxin can be neutralized somewhat by hot water. It has to be hot enough where it's almost uncomfortable, so you have to be careful, but it does help soothe. If the patient's in severe pain, I'll do a field block of 2% lidocaine or Marcaine, which Marcaine can last about 12 hours. And then, of course, I would say only one in, oh my gosh, probably one in 100 cases is the spine actually left behind. So usually the x-ray is negative, but this spine was left behind, so I gave it a good field block, completely numbed the area. And then with my 11 blade, I opened up a wide and deep enough path to use my Kelly clamp to get a hold of this guy, yank him out. And then local wound care after that. Okay, here's another one. This person, another foreign body case. Oh, this was horrible. Reaching up for something on the cupboard. Old wood slid underneath the nail. This one gets a digital nerve block. And again, my Kelly clamp pulled this out. This was just a piece of wood, a splinter. Most of these patients get a tetanus shot and maybe 3 days of antibiotic prophylaxis. But if they're healthy, it's just a tetanus shot. And I have found that antibiotic prophylaxis is not necessarily needed. And these patients do not seem to get infected. And here's another fun one. It's hard to see what this is. This is a wetsuit, and this is a bite with a lot of blood on the wetsuit. This is getting the patient out of the wetsuit. So this is kind of wounds that we see. This is a bite. This patient was scuba diving along a coral reef. And with wounds, we will do a local anesthesia, 1% lidocaine. This is with adrenaline because this was bleeding a lot. And then I rinse the room copiously, and I put my magnifiers on to look for foreign bodies before I suture this up and check it back 2 weeks later, in this case, to remove the sutures. This was a moray eel that snuck out and got this person. So let's see, I guess that I just wanted to share some of the foreign bodies that come in. Stingray rarely leaves the spine behind, but in this case it did. Moray eel, and
Great. And question?
that's it for some foreign body cases.
Great. Okay, question that comes up, I'll start with. In the event that you mentioned, for instance, stingray, sometimes it'll leave a foreign body behind, sometimes not. And making the assumption that some of these foreign bodies might be radiolucent, meaning that they would not show up necessarily on an X-ray like we see on these images, but perhaps radiolucent. Is there a role, again, especially in the field in limited resources, other than perhaps having a handheld ultrasound available? Two questions that come from that. Would handheld ultrasound be perhaps helpful to, at the point of care, without X-ray or even with X-ray and a radiolucent foreign body, have a role to be able to not only detect that there is something left behind, but also to teledirect the removal, right? Guidance, just like we use handheld ultrasound for injecting joints, etc., and tendons to localize the injecting needle. Likewise, would there be a role potentially for using handheld ultrasound to identify and localize a foreign body and help to remove it?
Oh, Dr. Pecchia, that's again, excellent question, and important. So I would again say that in any clinic, even with an MRI, with an X-ray, with subspecialists to consult to, the most important thing is our history and physical exam. And with foreign bodies, if the foreign body is superficial, I happen to show you a deep one. If it's superficial, it's often with your magnifiers and with cleaning the skin as well as possible, you can see it or gently palpate it and find it and remove it without anything but your examination skill set and taking your time and interacting with the patient. You will be able to localize it. As far as it being deep or radiolucent, that's a huge problem for us even in our clinics. And if it's radio opaque, we will send these to surgeons or podiatrists or whoever has fluoroscopy, and they will take these people to the OR under fluoroscopy and remove it. If it's organic material and radiolucent, then again, I'm glad I giving this talk. I'm going to have to review my ultrasound literature. I'm pretty sure the ultrasound is very good at this and is able to find radiolucent foreign bodies per your question, Dr. Peck.
Great, great. Yeah. And, and one of the reasons for this dialogue and this interchange is to identify opportunities to, pivot using alternatives to address issues like this when they happen in remote, under-resourced environments. So I'll be actually doing some literature search, have our librarian kind of help us out with that and really go deeper on perhaps presented later or posted on a collaborative website that I'll talk about actually before we finish today. So, okay. Any other questions on that case? And I think you have a fourth case, is that right?
We can do this last one. It's interesting, and let's see, let me throw...
Yeah, let's do it.
Okay.
This is great.
So here's a cardiac case, and I found this interesting and, again, chaotic, because this is a very young person, and I think well, let's get to my notes on this guy. So this is a 35-year-old male. I saw this person 2 years ago. He was healthy. He was a regular runner, and he had no known medical problems, no diabetes, no hypertension, no cholesterolemia, no family history of disease, specifically cardiac disease. And he came in complaining of chest pressure over the past 2 weeks. And he literally told me, sitting in the chair, I am looking at this healthy, fit 35-year-old man, and he's telling me that when he runs uphill, about halfway up the hill, he's feeling a sharp pain when he breathes, but it also is a pressure, and it's over his left chest and his neck. And he then has to walk up the rest of the hill, and it gets better. Then he runs again downhill, and he's fine. So I'm thinking to myself, can a 35-year-old really have new angina who's otherwise healthy? And I thought to myself, am I going to send this guy to the ER for a full cardiac workup? Or could this be wheezing, asthma of some type, pneumonitis, spontaneous small pneumothorax, pneumomediastinum? All of this huge differential diagnosis is sitting here in this chaotic urgent care clinic of mine. So I thought, for the first time, at least I have an EKG. I certainly don't have a treadmill, but I do have an EKG in my office. So here's at rest. Now, I have a guy in front of me. He's totally comfortable at rest, but he tells me about this story. Oh, I also got a chest x-ray that was normal. His exam was normal. His vitals were normal. And here is his resting EKG. Now, the cardiologists out there won't be happy with how I deal with my EKGs in the urgent care. It's not precise, but it does get the job done. And the first thing I do is I just look at the rate. I look at the QRS and I decide immediately, is this too fast, way too slow, or about right? And if there's any question, then I will measure out the rate. And the next thing I'm concentrating on really are the T waves and the ST segments. I mean, that's really our bread and butter, with making sure that this is not or is a coronary syndrome of some type. So I thought to myself, do I send him to the ER now? He's 35, he's healthy. Could this really be it? So what I did for the first time in my career was I just decided to walk him up and down the hallway for about 5 minutes. And actually I had him jog in place a bit as well. And I did not want to really reproduce the symptoms, but I was talking to him the whole time. We did not reproduce the symptoms, but I then after he ran a bit, laid him down on the table, and here is his post-exercise in my clinic EKG. And clearly he's flipped his T wave in lead 3, some maybe 1 millimeter, not much ST, but flipped his T wave. And then we're getting 1 millimeter at least of ST depression now in his anterior leads, V2, V3, V4. So I sent him to the ER. He had normal troponin, normal EKGs at rest, but he had a left main stenotic lesion, I believe, of 80%. I'm not sure it was that much, but he was stented and has been doing well ever since. And that's my last case.
Great, great. And as Jason commented, good catch. And
Thank you.
it's nice to save a life every now and then, right? After in primary care, lots and lots and lots of, things like foreign bodies and cuts and scrapes and minor fractures and such. But every once in a while, right, whether we're in a primary care setting, folks walking into your otherwise regular day at the office versus urgent care settings, and then again in a remote setting, a patient like this can be managed just as you did, right? So you were not in an ER setting, you didn't have a treadmill that you could send the patient to down the hall, put them in a monitored environment in a hospital and keep them overnight to rule out ischemia or an impending event or an active event, cardiac event. I mean, this was a great example of improvisation at the site and the type of care that could actually be delivered in a remote environment. Asking the question and having an answer to my own question, are there EKG devices that actually can generate beautiful EKGs like this that the patient can wear to then be exercised slightly in, let's say, a remote, otherwise under-resourced environment? Absolutely. And we have some experience with utilizing those types of devices, get them on site, and so that when we have cases like this that may walk in to the village clinic, let's say, that right away the provider has the opportunity to gain some additional information and at least triage a patient like this and get the aha moment that we're looking at right here, which is, oh my gosh, right? Look at those ST segment depressions, look at those T waves, and it's got ischemia written all over it. And then the take-home message, which is regardless of the patient's history, risk factors, age, this can happen to anyone at any time. Those of us who are a little older in the room remember the case of Jim Fix in the US. He was this is probably 30, 40 years ago when the running craze in the United States really started to take off. I believe this was in the story played out in the 70s, maybe into the early 80s. So a running guru named Jim Fix, Fixx, was really front and center with that movement. And I believe at age 41, he was in his early 40s, died of a heart attack, right? And with, no other clear history, although retrospectively it was found that he had a dyslipidemia, high cholesterol, and subfractions that put him at risk that evidently he did not perhaps know about. And then the evolution of occult coronary disease and someone who otherwise was looked at as a specimen representative of fitness and wellness and sudden cardiac death, right, which is a not uncommon cause of mortality in the United States. So, Dr. LaRue, those were awesome cases.
Thank you, Greg. Thank you.
And I really hope, there we go. Dr. Ruby, thank you for reminding of July 20th, 1984 was the passing of Mr. Fix. So good catch on that one. This is super helpful. We'll have some follow-up to answering some of the questions that got posed today. I'll have our librarian at Western U actually do some searches on this, perhaps for our next session. And also we'll post this in Figure 1, where we have a site where we'd like to now take our Global Grand Rounds episodes, post the episode, and some CME generating similar cases that are in the archives at figure1.com. And Marielle, you might want to put that in the chat for folks to be able to kind of go link to that. You can register to it. Once you're registered, you can send an email note to me, or just either in Figure 1 or to my email address. And Marielle, if again, you can post that in chat, www.figure1.com. That would be great. And then my email for anyone who would like to participate. Yeah, so we have all that there. Check that out in the chat. And then expect a mailing sometime within the next month before our next session of some of the answers to some of the questions that were posed today, and some representative cases that also you can review in Figure 1 and also obtain CME credit. Same type of CME that we had previously awarded for sessions, except the advantage of doing more than one case and generating, additional CME hours as you might find necessary. So, all right. Any other questions for the minute or two we have? If not, and I don't.
Yes, I have one. I have a question.
There we go.
Dr. LaRue. Yes.
Hello.
Dr. LaRue, in your first case where you were considering it might be cellulitis, how would you have treated it if it was cellulitis?
So all of these cases, you're reminding me, which I'm always thinking, okay, where is this host, this patient, in the evolution of this condition? So is it just cellulitis, superficial, getting deeper? Oh my gosh, could it get to this horrible septic necrotizing fasciitis? So to answer your question, if there's no vomiting, really no serious systemic, like SIRS signs, systemic inflammatory response signs, I just treat with oral antibiotic with good staph and strep coverage. Usually a first-generation cephalosporin, or even clindamycin. I'm using a lot of clindamycin if they're truly cephalosporin allergic. So strep and staph orally. If they're feeling nauseous, they might not tolerate orals, then in our clinic we use a lot of intramuscular Rocephin, or I use Ancef, which is another, that's intramuscular Keflex, basically.
Thank you.
That's how I treat that.
Great. Thank you, Mary, and thank you, Doctor, for that. And I'm sorry to say it looks like we are out of time. And Dr. LaRue, thank you again so much for sharing with us and getting the ball rolling again on some interactive case discussion, presentations and discussions like this. It's just super informative and a lot of clinical fun.
Great. Dr. Pecchia, thanks for having me. And Marielle, thanks for help with my laptop here. I appreciate it.
Yes, thank you for this informative presentation. And I'd just like to remind everyone that this recording will be uploaded to our YouTube channel within 1 to 2 days. And please use the link to Figure 1 in the chat box to register. Also, if interested, there's also a link to sign up for our monthly Global Gun Rounds. And with that said, our next Grand Rounds will be on June 12th. And as always, we appreciate your participation. Thank you and have a great rest of your day.